Really appreciate the opportunity to meet with you every year, and I spend a lot of time trying to think of what I'm going to say that's going to be helpful and meaningful. And you know, I started today thinking I'll title my speech "Autonomy versus Accountability," and you know, my goal was to really provoke you into thinking, and then more importantly into action. And there's a lot going on. You know, it is crisis time in healthcare. It is the worst time we've had in decades, with a lot of money being spent on healthcare, 17% of our GDP and growing. 1/3 of our dollars are, you know, being used for med-mal, defensive medicine, redundant testing, other things that really don't add value to patient care in spending it on. We have a silver tsunami of aging boomers who are having multiple chronic conditions, and this is going to be a challenge to face in the very near future because the capacities of our system are not yet there to deal with them. We have a significant shortage of primary care providers in New York State. We have a system of hospitals that are set up for acute institutionalized care, not on outpatient care. We're seeing an end of the fee-for-service system on the horizon. And this is extremely disruptive. I mean, how do you pay a colonoscopist not for the number of colonoscopies they do? I don't know the answers to that. But most troubling, we're also finding that we don't know who can best speak for the patient. Is it the hospital? Is it the physician practicing in a patient-centered medical home? Is it that brand new ACO that just opened up down the street? Can we, as physicians, still best speak for our patients? I think so. It used to be your parents were proud of you if you became a doctor, a banker, or a lawyer. Well, lawyers long ago lost that distinction. And frankly, the stock of bankers certainly went down with the whole Occupy movement. But what of doctors? What do people and the general public think of doctors as a profession now? Can we hold on to that vaunted role in our society of speaking for the patient, of best understanding their needs in the context of their families and communities? I think so. And I think that's why we're going to see a sea change. And your stock is going to go up very soon. Well, we just finished a budget negotiation session. And the things that we focused on, the top few things on the list are things like medical malpractice reform, limitations on retail clinics, and the boundaries around scope of practice for nurse practitioners and others. And I want to talk about these just for a few minutes. Unquestionably, number one on our list is medical malpractice reform. The government and the health department, we have continued to try and will continue to make every effort we can to reform this system that is broken, that doesn't serve patients, that doesn't serve providers, leads to increased costs, and we need to figure it out together, and we need your help because you know that we are trying. We are trying, but we need to do more. You know, the National Practitioner Data Bank in 2011 found that 6 states represented 51.4% of all malpractice payouts. California, Florida, New Jersey, Illinois, Pennsylvania, and New York. And the news gets even worse. New York's not only on that list, it had the highest total payout of over $677 million. And that's more than double the next state on the list, which is Pennsylvania. So we must fix this. We can't afford not to, and we will make progress. But if you take the main arrow in the tri-lawyer's quiver, what is it? It's quality and safety. That's what they claim is a problem, and that this protects patients. Whether this is true or not, and I don't believe it is, we have some serious problems to confront. To give you perspective, 2 batteries malfunction, and an entire fleet of 49 jumbo jet Dreamliners is grounded for months. And in healthcare, the equivalent of all 49 of those jumbo jets crash and burn full of patients every 2 months, according to statistics from the Institute of Medicine. You know, who do we blame? We blame the lack of coordination. We blame the system, rightfully. We sometimes blame our patients, but it's hard for us to blame ourselves, because it is the system that we're working in that needs to change. And we need to change it. How do we advance this science? How do we ourselves take hold of this and take that arrow out of the quiver? You know, just yesterday, the governor's two important proposals of the governor passed in the Public Health Council. One related to sepsis and one related to flu, masks for flu, workers who don't get flu shots. In New York State, if every hospital used an evidence-based protocol for the early diagnosis and management of sepsis, we would save 7,300 lives a year. Preventable deaths, evidence-based, checklists, stuff we know we need to do, stuff that works. Kaiser dropped their rates 60+%, and sepsis is the #1 killer in hospitals. And yet it took us and the governor to mandate it on the hospitals, to do the right thing. We need to step up. We need to do the right thing. Today in New York State, across all the hospitals, 48.6% of healthcare workers actually get a flu shot every year. That means over half don't even get a flu shot. So the governor and the Public Health Council has mandated that during the flu season, every healthcare worker in hospitals and nursing homes and diagnostic and treatment centers who don't get a flu shot need to wear a mask. It works. It protects patients. It works. Look at the experience of many of the hospitals, even in our own state, who've already started that. But we don't want the strong arm of the government telling us what to do. Or worse, payers. And yet they're all stepping into the void that we have created. We're starting to make progress. You know, the Choosing Wisely campaign is an excellent example of where doctors are taking the lead and saying, for these 135 things, it doesn't make sense that we do them anymore, or we should do them differently. When you have an elective preterm C-section, pre-39 weeks, we know the costs go up exponentially. The number of babies who end up in the NICU go up. Maternal outcomes deteriorate. And yet, the variation in preterm elective C-sections as high as 45% in some institutions. And we know, and we've said, that we are committing to decrease that rate down to only those really necessary cases. And so who is best to police us? Ourselves. And I'm very optimistic that we are taking those positive steps to really improve quality and safety and really regain the voice of the patient. The next issue I want to talk about is retail clinics. And I want to consider it along with scope of practice. We fight retail clinics because we know that they skim the easy, high-profit run. They'll give that shot. Yeah, they'll give the shot to the kid. They'll give the immunization to the kid, and then at midnight when the kid has a fever, who gets the phone call? Us, right? This year we had a proposal that considered limiting what could happen in retail clinics in the state of New York. Clear limits. They should not be allowed to sell tobacco while delivering health care at the same place. You can't just keep going there for all your care. You have to be referred back to a doctor, right? You have to share your data.
If you're there and you're in a retail clinic providing care, you have to share your data on the regional health information exchanges. And unfortunately, that proposal was not approved, and we are left with a void. And who steps into that void? Last week, in the retail industry's boldest push so far, Walgreens announced plans to expand medical services at over 300 take-care clinics across the country. The move by Walgreens puts them into a potentially lucrative business, according to them, of treating customers with long-term medical problems such as diabetes, asthma, high cholesterol, and the resulting prescription drugs and other supplies that can be supplied at their stores. What about patient-centered medical homes? What about handoffs between specialists and primary care for the best mix of services for their patients? There is evidence that retail clinics are here to stay and very likely to be expanding very quickly without clear parameters that we should enforce on them. And I'm asking for your help in doing that. And we fight against the independent practice of nurse practitioners on quality reasons. The reality is, if we put bounds that are reasonable and clear, we can go some ways to addressing the real shortages that exist across the North Country, the Southern Tier, and many parts of the state. There has to be some accommodation that makes sense from a clinical and a patient perspective that maintains high standards, but the scope of practice has to expand, because today, what do we have? We have over, as of January, we have 97 distinct areas in the state of New York, from the St. Lawrence County in the North Country to the Washington Heights Inwood neighborhood, not far from here, that according to HRSA, were highly underserved for primary care services. These 97 areas include 3.4 million people, almost 1/5 of the state's total population, people who can't get primary care services today because of provider shortages. And it would take 534 primary care docs just to get that designation to the next level, which is still a bad level of shortage. We'd need over 1,100 providers to really cover the shortages across this state of New York today. And that's not tomorrow, when we add another 1 million people to the insurance rolls by adding a health benefit exchange. And suddenly they have got a card, but they don't have access. So the problems that you see are only going to get worse unless we have creative, collaborative solutions on understanding what is the best mix of providers to meet the needs of a given region. What is the best use of technology to meet the needs of the people? You know, we propose, it's really good to define a business, and it is becoming a business by what consumers want, and not just by what a company can produce. Today, doctors and hospitals are producing health care, and what people really want is help. We know what health is, and we, on the front lines of healthcare delivery as doctors, can help produce health. And that's why your stock is going to go up. Because you understand that patient really wants this quality of life. And what does it mean, 5 medicines versus 8 medicines in terms of their quality of life? No one can answer those questions except frontline providers. And when the systems start to understand that there's only one person who knows what the patient really wants, your role will increase, and ideally your pay will increase as a result. But we need to change that thinking from an input-output model to an impact-outcome model. And that's really hard. It's easy to count things. I did X, I did Y, I did Z. It's very hard to say, how did we manage Mrs. Jones so her quality of life improved? What is a unit of quality of life that my services impacted? those words are hard. And to the credit of the AMA and the Medical Society of the State of New York, they're working very hard to help give you the tools that you need to do this. You know, just last week, I don't know if you checked your email, I got an email about the AMA's Improving Health Outcomes Initiative. Really exciting, and the words that they use include things like selecting a set of clinical and patient-reported outcomes for a national dashboard, collaborating with other experts on improvement strategies, with stewards of data to determine population-level rates of these outcomes, setting national goals for improvement in these outcomes, identifying effective strategies that achieve the three-part aim of better care, better health, and lower costs, validating the identified leading practices and improvement strategies, engaging physicians and care teams, tracking population-level health outcomes, and on and on. This is great stuff. A lot of it is Greek. What does it mean for a population-level health outcomes when you're serving 2,500 patients in a busy neighborhood with a lot of other people serving those patients' needs as well? I don't know. But we need to figure it out. We need to figure it out. So I started thinking about autonomy versus accountability and saying it's a choice of either or. But it's not. It's us finding a way to embrace both. We can have it all. Accountability, the way that it's been defined for us, give us all your data and we're not going to give any of it back in any meaningful way, and that's accountable. We'll pay you based on what we think is worth paying for. That's accountable. That's changing. We need to define what is accountability. And that way we can have our own autonomy as well, to actually practice medicine for the patient's best interest. It's about being accountable in that new definition that we actually help define to our patients, our peers, and ourselves, but also retaining that autonomy in our work by practicing at the top of our license, by maintaining the dignity of our profession, by advocating for our patients' needs as only we can, and recapturing that position in the healthcare delivery system as the ones best able to give a voice to patients and their needs. Thank you very much.
Dr. Shah has graciously said he's going to take some questions from us.
Yes.
Thank you, Dr. Shah. I'm Dr. Skavis, Queens County family practitioner. A couple of comments on probably why there's not enough family doctors. The first being the predatory practices of HMOs. The fact that I get probably $20 for a 30-minute conversation with my patient on health care. The fact that you talk about the practice of medicine and the patient's best interest, but in order to look at my microscope, I have to pay a $200 CLIA charge. All kinds of little things which I believe would help primary care, such as the expansion of vaccines for children to include those from insured HMOs, because I'm on several executive committees of HMOs, and they don't pay me for what I have to pay on my MasterCard to get these vaccines. Thank you.
You're absolutely right. And the thing that's going to help you and everyone in the future is that we're starting to understand total cost of care. And when we see what we're paying, and what we're paying as a result of not paying for the right things in the right way, and people end up ill or in hospitals, one day in the hospital negates a year of high-quality primary care. When we see that, because we finally have an all-payer, we're building the all-payer claims database, and we understand the tools across payers, across patients, across settings, that's where finally we'll be able to assign value to what you do and make your life easier. But remember, there's a recent study done, and a friend from IBM told me that they followed around nurses in hospitals and looked at time and motion studies, you know, stopwatches of what they're doing. Fully half of what a nurse did, fully half was wasted. You didn't need a nurse to do it. And I suspect that because we haven't had the opportunity to fully embrace IT the way other businesses have, we haven't been paid the right way to afford the tools that we need, that we know we need, we end up doing things that we don't need to be doing. And my hope is that as we transition and better align these incentives, and we just give you a tranche of money to take care of patients, you can decide for yourself what you need best for your patients and how to distribute that work. That's happening. That's happening under shared savings and gain sharing and all that. It's happening not fast enough. It's not happening very easily, especially with smaller practices. It's not happening in many areas, but it has started to happen. And where it has started to happen, primary care, the number one thing that happens when that happens is primary care providers and doctors get paid a lot more. Not happening enough, not happening yet. Here, in your practice, it's happening across New York in small pockets, and that's why I think it can happen everywhere else.
Good morning, and thank you very much for coming, Dr. Shah. My name is Sheila Bushkin. I'm from Saratoga County. I'm speaking as an individual and also on behalf of many colleagues, some of whom are present here today and many who are not present here today. Thank you very, very much for your insightful guidance on the enormously important subject of the hydrofracking in New York State. Your recommendations to hold off natural gas exploration in New York State for several years in order to await the results of the Geisinger and University of Pennsylvania studies and the EPA study, as well as probably many other studies that will pop up over the next several years, puts New York in a leadership position, first of all, and second of all, really protects the health of the people of New York State immensely and saves New York State an ever-expanding state and personal health care finance bill. We think that with your decision, revealed not only great wisdom and powerful leadership because of expected intense pressures coming probably from industry, but great leadership also within the government. And we want to thank you for your decision.
Well, let's go to number 3. We'll go back and forth.
Thank you, Dr. Shah. I'm Eric Eiting, emergency physician who trained here in the Bronx. First of all, it's really great to hear, and I think I speak for everyone in this room, to hear that both you and the governor have put medical malpractice reform as your top priority. We very much appreciate that, and if you could convey that to the governor, that would be great. You referenced several times about the primary care shortage that we have here in New York. In 2016, we get to the point where we'll have more students who graduate from U.S. medical schools than we actually have residency slots in this country. In fact, this year we saw there were 1,100 students who did not match. These are people who now have no pathway to licensure as we stand. They're coming out of medical school with an average of about $170,000 worth of debt. What is it that you think that we can do? Because I think that this is a great breeding ground for some trial projects. What is it that you think we can do to marry the primary care shortage and the impending crisis that's coming with medical education in terms of making sure that we can make sure that all of our patients are taken care of and students who go to medical school are able to obtain that pathway to licensure?
You know, again, one of the this points to another part of the broken system, which is the GME funding, graduate medical education funding, and we are falling off a cliff there as well. New York stands to lose a lot under the current proposals on the table, and we've been very active and vocal saying that this is not going to serve America's needs. We train the vast majority, compared to every other state, much more than every other state, of residents and physicians ultimately. And yet, the problem is we're not training the right mix of them, and we can't keep them in New York. So to the governor's credit, we've been funding programs such as the Doctors Across New York program. We're funding high-quality primary care residencies in places and specialties in places across the state that are traditionally underserved, doing things like loan repayment and expanding on those programs to keep people in New York. We know those are working. They're small, but they're working. We need to do more of them. To the extent that the overall country's problems are something that we need Congress and the feds to step up and start to fix and pay attention to, first of all. We're writing op-eds in the Times and elsewhere to try to bring attention to these real problems. And I think give them a few years as Congress gets a little older and they can't find their own doctors, they'll suddenly wake up and say, we need to fix this problem. Yes, number 2.
Thank you. I'm Joe Sellers. I'm an internist and a pediatrician from Schoharie County, rural area in New York. My practice is a level 3 medical home.
Congratulations.
Thank you. And we have, the reason I'm able to be here today is because I have a partner who is having her loans paid off by doctors across New York, who we recruited, so she's able to cover the practice today. But last week I met with another family practice resident coming out of the Albany program who grew up in the town right next to us. She has over $200,000 in debt. And if doctors across New York were funded for new positions, I'd have another partner. But I don't think we're going to get her because the budget did not include any funding for new doctors across New York participants. So I thank the governor for getting the current participants to be refunded because I don't want to lose the junior partner. But again, it's a successful program. Maybe it's been a little undersubscribed, but for the niches where it's worked, it's been very successful. Money very well spent. And I think it was short-sighted not to include new doctors across New York participants in this year's budget.
You know, I don't think it was it was about hard choices. And the fact that there was money to at least maintain some and not cuts, as we saw in just about every other program, means that doctors across New York actually won. As someone who's writing checks to Sally Mae every month, actually it's auto-debited from my checking account, I feel the pain of paying off loans firsthand, and I know the importance of how that makes a difference in getting folks to stay in, because we haven't fixed the reimbursement system yet to get the pay where it needs to be. This is a bridge to getting there. I think we have number 4, and then we'll come back to number 1. Please. Yes, back there.
Dr. Gelfand in Nassau County. Dr. Shah, thank you for coming. But I wonder if you could tell us the specific malpractice reforms being considered.
You know, the issue is not about specific, there's a lot that has been discussed. The issue is where does the discussion start and where does it end? And I think if you ask your leadership where the discussion ends, it's one of the other branches of government. That's where we need your help to just get the conversation restarted in the legislature. That's where the ball lies.
I'm past president. I just want to say I've been involved in malpractice negotiations dating back to Dr. Mario Cuomo. And we have yet to hear specific recommendations from the government.
Abe Levy, internist in Fisco. Thank you for being here, and thank you for making malpractice reform a priority. 3 years ago, the federal DEA approved the electronic prescribing of narcotics. And we've been waiting 3 years for New York State DOH and New York State Board of Pharmacy to issue the regulations that would allow us to do that in New York. And as you know, that would make narcotic prescribing much safer and higher quality. When are we going to see the regulations?
Well, thank you for your question. This is one of the public health